Very good afternoon to all of you. I thank the organizing committee to giving me the opportunity to talk about this very dangerous situation where there are neurological problems. So, diagnostic dilemma in cervical myelopathy and its mimicker. Now, I will take you through this case report from Louis Robel. A 74 years male, he presented with progressive weakness of all four limbs, decreased sensation in arm and leg, difficulty in passing urine and hyperreflexia. So the MRI showed C3, C4 compression and the diagnosis of CSM was made. He was decompressed and instrumented fusion was done. He showed a progressive improvement and he regained his ability to walk. But what happens after 6 months, the improvement plateaued. The repeat MRI showed adequate decompression. And he had the persistent some signal changes in the cord which was there earlier also. Subsequently, there was unexplained neurological deterioration. He became wheelchair bound, he was areflexic. And there was just diffuse muscular atrophy. And the EMG, it diagnosed that he is a case of, in fact, MND. Now, there are several reports in the literature, and you will find there is cervical spinal myelopathy and there is associated mimickers, and it is extremely important to know this. Now, if you see the etiopathogenesis, these two are wide apart. Then why there is a confusion? Confusion is because of the clinical presentation and it creates the dilemma. Because both these group patients, they are middle-aged or elderly patients, there is a slow progression, there is a varied or overlapping neurological presentation. Mild and moderate symptoms patient is having, but he suddenly deteriorates. He deteriorates in CSM because of the small jerk, and in MND it is because of the bulbar involvement. And there may be 3 clinical settings in cases where you should know cervical myelopathy is a classical case of cervical myelopathy with all signs and symptoms and radiological finding. MND, there is no obvious significant neurological radiological parameters or finding. This is the last one and the worst one where there is underlying MND, and you should be aware about that, investigate and explain to the patient. So it is extremely important to know in detail the MND and cervical myelopathy, which is a spondylolytic variety. Now, MND, it involves only the motor system. Usual age is 40 to 60 years, and cause of death is usually because of the respiratory issue. He is the famous scientist who practically defied MND. There may be UMN sign, LMN sign, or both. There may be bulbar palsy or pseudo-bulbar palsy. There is usually difficulty in swallowing, deglutition, and speech. Eye movement is never affected. Bowel, bladder, and sexual function maintain is absolutely normal. These are the very important findings. If you see this motor track, it starts from motor cortex, goes through internal capsule, midbrain, pons, medulla oblongata, where it decussate, and then it ends into a spinal cord from where the anterior horn cell and the motor nerve start. If the lesion at the place 1, you will get progressive spinal muscular atrophy. If at 2, you will get primary lateral sclerosis. And 3 is the combination which is the most common one of the MND, that is the ALS, that is amyotrophic lateral sclerosis. If there is involvement of the cranial nuclei, it is a bulbar palsy. Higher to that is the pseudobulbar palsy. So it is important to know the clinical finding in each case, then you will never miss it. There may be limb onset or bulbar onset. Bulbar onset is usually in the form of dysarthria and dysphagia. Cause of death is usually respiratory paralysis. EMG is the most important diagnostic tool. Rest all are almost normal. So it is the investigation of choice where you get denervation changes. There may be spontaneous activity at rest, and fibrillation is the diagnostic feature. Nerve conduction studies are usually normal, and muscle biopsy shows atrophy. There are 2 important criteria for this MND, that is the Scorial criteria and Awaji-Sima criteria. In Awaji-Sima criteria, there is an inclusion of EMG finding also. So you can have definite ALS finding, possible ALS, probable ALS, and suspected ALS. Now this chart is important where it has been defined when you say it is a definite ALS, probable ALS, and possible ALS. It all depends upon the regions which is involved. Cervical myelopathy is absolutely a clear-cut case where you have a classical picture and there is no problem. There is a compression of the spinal cord. It may be anterior, posterior, or there may be circumferential. Remember, both sensory and motor tracts are involved. Why there is a confusion? Because sometime in the CSM, there is root involvement, and that also gives you element sign apart from human sign, and that creates the confusion. Otherwise, it is very specific feature it has: tingling, numbness, grip weakness, clumsy gait, sensory, motor and bladder involvement is seen. There are no bulbar symptom, and they are the severity and prognostic criteria where the JO score or modified JO score can be used. Radiological examination tells that all these features are very classical of CSM. There are compression. You can see also in MRI, spinal cord compression ratio tells you the prognosis of these cases. In CT, you can see osseous compression. DTI is actually a biomarker, imaging biomarker in the cervical spinal, myelopathy. There are two factors, FA factor and ADC factor, which also gives you a prognosis. And this is an important tool nowadays for CSM, and you can see the progression. So what are the points to differentiate? So in CSM, you have both sensory and motor involvement, but in MND, it is only motor. Cranial nerves are not involved in CSM, which is involved in motor neuron disease. No bulbar symptom in CSM. No fasciculation, which is very important there. Tongue is normal. Here, the tongue is involved. There may be fasciculations of the tongue. Bowel, bladder may be involved in CSM, which is not there in MND. Classical X-ray, CT, MRI finding we will find in cases of CSM, which is usually normal in motor neuron disease, but in some time, because of the age-related changes, you might find some. This is extremely important. Transcranial MAP is always abnormal in motor neuron disease, remember. So this is one of the very diagnostic, and this was nicely presented in this paper, and this is the hallmark and a very important investigation. So I'll conclude. It is extremely important to beware of CSM and its mimicker. Thorough clinical examination, close follow-up, radiological and electrophysiological study is extremely vital in these patients. One should beware of overlap of clinical presentation and underlying associated different pathologies, so that a proper counseling of the patient can be done. I thank you very much for your kind attention.